The problem is, or the challenge is, how can we pre start of a treatment best predict which patient will do good on which therapy. So what I pointed out is I took the iwCLL 2018 criteria as kind of a starting point, saying if you look to all those factors that you are yes or no recommended to do, is that still valid? And I made a few conclusions. One is that outside trials in the iwCLL, we are still supposed to do the complete FISH panel. And the question is there any prognostic or predictive value in other chromosomes than del17p? And I think there's actually not. Del11q, which is still also in very recent trials, still used to randomize or to stratify. I think that's a bit obsolete now, because there is, with the addition of R to FC and with all the new agents, there is no clear pattern of a worse prognosis for 11q patients. Same is true for trisomy 12. So I think 17p, you really should do. The other markers is not that relevant for clinical decision making. Then I made a point about complex karyotype. I think there is so much evidence now that either CBA, so chromosomal binding analysis, more the very laborious old-fashioned way, you can say, of looking at chromosomes, or maybe the more modern and maybe a more easy, as long as we can standardize it, way of doing it is by digital assays. So looking at genomic complexity, I think that information on complexity, where we have to very sharply look at the definition, 3 or more, or probably better 5 or more aberrations. I think that is very predictive of a patient with a poor prognosis, who you might think of a more intensified treatments than other treatments. I discussed the role of CT scan. Forever, actually, was very big discussions in the iwCLL whether or not a CT scan should be mandatory, like we do for lymphoma. For a long time, experts have said, well, outside trials, there is no additional value to do a CT scan in a leukemia kind of disease. And I think that also changed, specifically when we now have drugs like Venetoclax, where you use the CT scan not so much to know whether a patient should be treated or not. You do that on physical examination and on blood values, but to assess the risk of a patient and how intense you should monitor the patient for risk of tumor lysis syndrome. I think there is a role. Then I discussed also the role of CT scans, which is always almost mandatory every 6 months, or even sometimes more frequent in mostly pharmaceutical sponsored trials. And although you get very quick data, so you see very much earlier progression if you do CT scans and if you only do by physical examination and by blood tests, the question really is how worthwhile that is, because we know that from the time of progression till time to next treatment, there can be months and even in some studies years in between. So the question is, how relevant is that? So to conclude CT scan, I think you should do it if you want to think of a therapy which, like Venetoclax, where a CT scan will help you to guide how intense your patient should be monitored. For prognostication and for following the patient, I don't think there is a place outside trials. And the last point I made is more the patient-related factor, and that is that we make a very big thing now, very lively discussions on BTK inhibitors and which BTK inhibitor is the best one to prevent cardiotoxicity. And my problem there is that we don't really have invested enough, I think, in developing good tools to predict which patient is really at risk or not. So it's interesting and it's helpful that we have maybe some inhibitors that give, instead of let's say 10% chance of AFib into 5 or 6%, or 4% of sudden cardiac death into 2%. There's of course of value, but much bigger value is, can we upfront predict patients who are of cardiac risk, and maybe those patients should not be treated as a BTK inhibitor at all. And so that was the point, that I think we have the data with all the trials that we have done, both in study groups and in pharma, and we should take the effort and the time to invest to really see, maybe by machine-based learning, which patients are actually at risk. So that was a very short summary of my iwCLL talk.